Hi there, this is Dr. Peters, and I'm going to talk about treatment of tobacco dependence. This is one of my passions. I finished my DNP, and that was my main focus, and I've spent a lot of time since then making system changes within Cessation, as well as now out in the community, going out to workplaces to help people quit smoking. So I'm sure all of you have been affected by smoking in one way or another, family members. I mean, when I was a kid, I was a 70s child, 70s and 80s, pretty much walking through a cloud whenever we'd had family gatherings. So I've been exposed to secondhand smoke, third-hand smoke, which is, on carpets and couches and clothes and walls and that kind of stuff. So anyways, we're going to talk about this because it's still a problem. In 1948 to 50s, half of the United States smoked. It was promoted. We thought it was good for you. Doctors advertised it as being healthy. Santa Claus dressed up. Someone dressed up as Santa, and that was a commercial. It was supposed to be glamorous and cool. Well, we found out, no, that's not really cool. Cigarettes were designed for addiction. The R.J. Reynolds and the other tobacco companies designed these cigarettes for addiction. So there's thousands of chemicals in it, and basically when you exhale a cigarette, you're exhaling about 4,000 chemicals because of the reactions that are happening from all the chemicals that are in there, which are multiple. So you can look that up, and it would, if you are interested, if you go to the R.J. Reynolds website, they have to show you every ingredient, and you would just be amazed at the ingredients that they put in a cigarette. So it's not plain tobacco. Not saying tobacco is good for you, but again, the tobacco companies very much manipulated us, and it's, I tell the people that I'm trying to help quit smoking is you should be angry at the tobacco companies that really manipulated you into thinking that smoking was okay. We all started, and then it's designed for addiction, so we can't quit. But you can quit. People think they can't quit. Okay. All right, so I'm going to talk to you on this one. I'm going to talk to you more about pharmacotherapy on how to treat, as well as the guidelines. As you can see now, at this time, we are down to about 17.3% as a nation, but if you go to Wisconsin and the counties, we're up as high as 25%, say in Milwaukee County. Ozaukee County is actually pretty low, one of the lowest counties. There's 72 counties in Wisconsin, and Milwaukee, Racine, Kenosha, and well, there's a couple other ones that are still high. Regardless, we still have smokers. We still have billions and trillions of dollars spent on health care for people that end up having heart disease, lung disease, bladder cancer, COPD, as well as multiple other cancer-related or smoking-related illnesses, loss in productivity of work because they end up missing work. So what we need to do is we need to identify every single tobacco user, meaning at every single visit, it's part of the meaningful use by the government that they set forth that we have to, now it's just a given that we need to ask. That's not being tagged anymore, but now it's gone further, and we need to provide counseling for all of those that smoke or have recently quit smoking, because we need to check for relapse. Anybody that smokes, you need to say the best thing you could do for your health is quit smoking. It's a simple message that we give them. Most people have heard the lectures over and over again, but it doesn't matter because it's found that repeated messages will end up getting that person to eventually get to want to quit. You have to want to quit in order to quit. So it's getting to that. If they don't want to quit, then you give them advice, and you give them like the 1-800-QUIT-NOW. Wisconsin Tobacco Quit line. So these are the 5 A's. Ask, advise, assess, assist, arrange. All right, so asking, you're always going to ask. You're going to advise to stop. If people are willing to listen to you and they really are interested in learning more about that, that's when you're going to assess, assist, and arrange for follow-up. Assessing is they'll tell you their story. Assisting is you're going to provide pharmacotherapy if needed, come up with a plan, and arrange for a follow-up visit. Assisting is you can't, this is like changing a behavior, and you cannot get rid of habits without replacing it with another. If you read The Power of Habit, and also if you read the book Triggers, if you guys are into that stuff, it's just really good to let you know, you nearly need a plan to quit smoking as well as anything. If you're addicted to chocolate even, as that is, we know you can be addicted to chocolate, but you need a plan to quit smoking. Otherwise, you will you risk the chance of being unsuccessful. It's a high rate of that if you don't have a plan. So, assessing. Are you ready to quit within the next 3 to 4 weeks? Yes, I am. All right, let's go to the calendar, or I want you to go home and look at your calendar, and I want you to pick a date within the next 4 weeks that you want to quit smoking. So then they go and they pick a date. All right, February 1st, I'm going to quit smoking as an example. All right, let's get a piece of paper out. Let's write down, what are your triggers? Write down what their triggers are. Getting in the car, with coffee, with beer, bonfires. I mean, I've heard it all, the different triggers that people have. After you eat, etc. After intimacy, that's a big trigger. So what are you going to do instead of those things? So it's basically helping them work through those things. When I go out to companies, I am trained by the American Lung Association, and we spend a great amount of time helping them to change to healthy habits. People worry about weight gain. Yeah, there is evidence out there that they will gain, or you can gain approximately 5 pounds. But again, if you change your habits to something healthy and have a plan, instead of saying I'm going to eat chips all night because you're stressed out and you can't have a cigarette and you go for the ice cream or whatever because you don't have a plan, then yes, you are probably going to gain more weight. Okay, so cessation rate, as you can see with counseling, it's much higher versus none. There are those people that quit cold turkey without anything. That's fantastic. But a majority of the population needs some counseling and motivational interviewing, which is within that. So again, when I say express empathy, express compassion for the person. You may not have ever smoked, but express compassion. It makes it easier because I smoked. I regret starting smoking, but I did smoke for 4 years, and I know what it's like to quit. I tried quitting about 10, 12 times. So thankfully I ended up quitting, as all my grandparents all died from smoking related illnesses. My father passed away last year of that also. And don't just think of lung cancer as being a smoking related illness. I mean, my dad had severe vascular disease from smoking. He had 2 carotid and both bilateral carotid endarterectomies. He'd had stents put in after that. And then there was a blockage a month before he died in the bifurcation that he was supposed to go to a specialist, although I don't think that they would have done anything. He already had stents in his iliac arteries. He needed a FEMPOP bypass, but he was too high risk. He ended up dying from an ischemic bowel. So, I mean, it happened suddenly, boom, boom, severe pain, went into the hospital. He died 24 hours later. So it was sad. It was awful. But then again, I'm glad he didn't suffer because he had emphysema end stage and he was on oxygen. And I'm glad he didn't suffocate himself, because it was pretty bad. Anyways, so that's that. Just to let you know that there's more things than just lung cancer, and because that's what we think and relate to smoking. All right, so we talk about motivational interviewing, obviously not arguing with the patient. You just got to kind of listen to them and say, yeah, I understand how you feel. What if we do this? What if we do that? Or why don't you go home and think about it and then come back? So let's talk about some pharmacotherapy, because that is what we are equipped to do also, in addition to motivational interviewing and helping them. So combination pharmacotherapy is actually we found that's more efficacious for helping people quit smoking. So what we do is we go through, there's 5 nicotine replacements and there's 2 medications. The 2 medications are Zyban, which bupropion is the generic name, and then there's the varenicline, which is the Chantix. The Wellbutrin, the Zyban, okay, let's go back. Wellbutrin has been used for depression for quite a few years, but then they found that people that were on the Wellbutrin for depression really didn't have a desire to smoke. So they went and did some clinical trial and came out with Zyban. Zyban is the same thing as Wellbutrin, the generic's bupropion, but so now we use it for smoking cessation in addition to it being used for depression. And then we have the nicotine replacements. We have the patch in 3 different doses, 7, 14, and 21. We have lozenges in 2 and 4 milligrams. We have the gum in 2 and 4 milligrams. We have the nicotine inhalers. And then we have the nasal spray. Nicotine inhalers and nasal sprays are usually not covered by insurance. They're expensive and they're rarely ever used. I think I've prescribed an inhaler once and have never done a nasal spray. There's side effects to all of these. The nasal spray can cause a lot of burning, so people usually don't really tolerate it. We can mix a nicotine replacement with bupropion. You can also mix varenicline with bupropion, although it's not done very often. But when you're thinking of combining, studies have shown that combining them help people quit smoking. Some people do single, so it's very tailored to the patient. So as you can see here with combination therapy, that the ones that had the bupropion plus the lozenge have a higher quit rate than people that are just on the lozenge or the patch. But it's good with the patch and lozenge, so that gives you an idea. It's actually recommended that you use 2 nicotine replacement therapies. You can actually do triple therapy. So since the guidelines have come out in 2008, there's been a lot of studies that have come out that show triple therapy are fine to use and recommended also. So we need to be careful with it. But again, for example, when you're using the lozenge is more of a quick release of nicotine. So it's really good to, if people get up in the morning and they have a craving with about 30 to 45 minutes upon awakening, the lozenge is really good. So many times we'll put people on a patch and then they can use the lozenge as needed during the day, as well as they can be on bupropion. Varenicline works a little bit different. It's completely different, meaning that it blocks the nicotine receptor sites in the brain, so it makes your brain, supposed to make your brain think that you've already been satisfied and had a cigarette and don't need that dopamine release. Remember, there's a lot of chemicals that go into us feeling good. It has to do with our appetite, etc., but also with addiction, that you need that dopamine release. You smoke the cigarette, it's going to the nicotine receptor sites, dopamine is released as well as other chemicals, and then you're satisfied. Well, the varenicline Chantix blocks those. So it used to be thought that you should not give a nicotine replacement with the varenicline, but there are some preliminary new studies out that those that used varenicline or Chantix with a nicotine replacement actually had a higher quit rate. But it's not prescribed very often. So in summary, you can do the varenicline, you can do with a nicotine replacement, although I'm kind of waiting for the new guidelines to come out. Bupropion can be mixed with a nicotine replacement therapy. That's what I would recommend. You can mix 2 nicotine replacement therapies. Or you can do triple therapy, which would be your bupropion and 2 nicotine replacement therapies. Right now, the guidelines are the 2008 guidelines. There are new guidelines that are being worked on right now. So I'm thinking within the next year or 2, we should see updated guidelines. Because now we have a whole new ball game with vaping and just more research. A lot of research has been done since that time in 2008. What do we do with vaping? Well, we don't recommend vaping. We still don't know a lot about it. We know there's propylene glycol in vaping. We don't know what that does to us long term. It can't be good to inhale those types of things in our lungs. We also know with vaping that they have many flavors. The contraptions look really fun. It's tripled in use in teens, and cigarette use has gone down in teens because they're doing the vaping. The vaping flavors are FDA approved for digestion into your stomach, but they're really not approved for inhaling, but they get around it that way by saying it's FDA approved flavor. So just think about that. So let's go back to the slide. There's so many things I like to add in here because it comes up in my head and I think it's important to know. Long-term medication use, smokers who report persistent withdrawal symptoms, that's good for long-term medication use. Those smokers who've had relapse after stopping the medication, smokers that are higher risk for relapse. And smokers who desire long-term therapy. So these are all people that should be more on a long-term medication use. So the bupropion, they should be on for at least 6 months, 9 months, and the Chantix for at least 6 months. It used to be recommended for 3 months, but the newest study shows that if they're on it longer, they're going to stay quit. And this is the problem, is that people start feeling better and think they don't need a cigarette, so they stop the nicotine replacement or the medications too soon, and then they relapse and start smoking again. Okay, so I'm just going to briefly go through these. It's about quitting prematurely and their relapse rate. And it just shows that people are on it longer, quit longer. This is the varenicline, that's your Chantix, on what happens when they continue on with it. All right, so nicotine patches. Nicotine patches come in 7, 14, and 21. So depending on how much they smoke a day, if it's a half a pack, you can do 7 milligrams. They smoke 1 to 1.5 packs, you go to 14. If it's more than that, they do 21. You do each dose for approximately 2 to 3 weeks. You can go up to 6 weeks on each dose, and then you taper it down. That's why it's good to tailor it to each patient. Okay, so it says right here how many cigarettes a day and what the dose of the patch should be. And I've never done 35 to 42 milligrams. It's like putting on a couple patches. So I've never done that before with patients, so I don't want them getting overdose of nicotine. And that's what you have to tell them. If they're on these nicotine, don't smoke because they can get sick. It increases your rate for heart attack. Okay, so I already talked about this. The one thing is to use overnight, some people get weird dreams with it, so sometimes I'll tell them to just take it off at night and put it back on in the morning. Before I start case number 1, I also want you to be aware, I'm sure you're aware of hookahs, as well as now there's juuling that's out there that's used with the vaping. Juuling looks like a USB drive and goes into this little contraption, and it's basically like smoking 5 packs of cigarettes. No, that one's like 1 pack of cigarettes, I think. I know that the hookah, though, is like smoking 5 packs of cigarettes at once, so it's actually worse for you. Cigars, inhaling cigars, the more it ages, the more concentrated it gets. Those inhaling are not good for you, or even if you don't inhale, there's always some that gets in. There's also a lot of stuff that you can get next to the counter, and this is what's happened. So I don't know if you remember in the 80s they had Joe Camel that was really enticing kids, and they've done a lot of stuff to entice kids to start. We don't want teens to start because those are the people that start and have trouble quitting. They don't quit, and so here we are in this boat now with a population that smokes. So the earlier we can catch them to not start smoking, the better. But what's happened is, again, the tobacco companies have tried to gear it towards children. Well, they got in trouble for that, and they can't do that. It's illegal to do that, but again, they still get around it. So what they do is they make the packaging the same color as candy. So they take that same dye color. So if you just take a gander when you go into the store, look at like the cigarellos, and they have like Swisher Sweets, different flavors of things. if you take a look at the colors and then go to the candy aisle, you'll see that they're the same, because we've taken candy and those and put them on a plate, and it's really hard to decipher what's the candy and what's the nicotine. So there's a lot of stuff out there. People are also putting marijuana in the vaping, and then you can't smell it. So, all right, case number 1. Let's do a 55-year-old man with coronary artery disease. So he had a stent put in 6 months ago, and he's still smoking. Not good. He smokes, he gets up and just has a cigarette. He quit smoking for 2 weeks. Tried a nicotine patch after a stent, but was a bear to live with until he relapsed. His wife probably said, "Oh my gosh, go have a cigarette, you're driving me nuts." He's here for a follow-up with you, and he's willing to try to quit smoking again. So which of these recommendations would result in the best tobacco abstinence outcome 6 months from now? And we're talking medications. Besides making a plan, would we do the 21 milligrams per day? Let's see, he's doing 25 plus. He's smoking quite a bit. For 8 weeks? Or the gum as needed for 12 weeks? Or the lozenge as needed for 4 weeks? Or the patch plus nicotine? Or the bupropion for 7 weeks? So I'm looking at this and I'm thinking, well, this guy needs combination therapy for one thing. At least combination therapy. So I'm going to pick 4. So yes, it is 4. When people go to the store, it'll say on the packaging not to use another nicotine replacement. You can. It's in the guidelines. You can do that. So take home number 1 is brief behavioral treatment is effective. Although it's more effective for ongoing, pharmacotherapy is effective. We talked about that. Behavioral and pharmacotherapy together are the best. And combination pharmacotherapy results in superior abstinence compared to a single agent. Using combinations in smokers who've tried and relapsed with monotherapy, and smokers with important comorbidities. Use pharmacotherapy for at least 12 weeks in everyone, and consider high doses for heavier smokers. Treat those at risk for relapse for at least 6 months. All right. And that is it. If you have any questions about tobacco stuff, ask me. I love it. So I don't like tobacco, but I like helping people quit.